Hello friends, welcome to another episode of Movers and Shakers, where we bring to you movers and shakers who want to share their experience and expertise in their respective fields. So let's see whom do we have today. We have Nathaniel Lawson. Nate Lawson is the Director of Division of Biomaterials at the University of Alabama at Birmingham School of Dentistry and the Program Director of the Biomaterials Residency Program. He has over 150 peer-reviewed articles, book chapters. He's published and studied the material extremely well. He is also the recipient of the 2016 Stanford New Investigator Award and 2017 3M Innovative Award Fellowship, both from the American Dental Association. He serves on the American Dental Association Council on Scientific Affairs and is on the editorial board of the Journal of Adhesive Dentistry and the Compendium. He has lectured nationally and internationally on the subject of dental materials. He also works as a general dentist in the UAB faculty practice. Please join me in welcoming Dr. Nate Lawson with us. Thank you. Once again, Nate, I really appreciate you doing this for us. This is such an honor with such a wide expertise in the field. I am so much looking forward to having this conversation with you. So I welcome you to our show.
Oh, thanks so much, Rajiv. I appreciate being here virtually and look forward to having a discussion.
So as we discussed earlier, our topic is going to be some common myths in adhesive dentistry, which a lot of questions come up, and we're going to have a few questions today and hopefully a few more in the future shows with you. So let's get on with the topic. So one of them is, do one bottle adhesives rival the clinical performance of two bottle systems?
So that's a great question, because I think if you talk to the real dental nerds out there and they want to use the highest level of bonding, the two bottle systems have been getting a lot of attention. Some people call these the gold standard adhesives. At the same time, like if you look at the market data and like what people are actually buying, and there was a recent ADA poll that showed the same thing, that one bottle, kind of these universal adhesives are what's dominating the market, at least in the US, and I'm guessing probably in other countries as well. So the question is, can these one bottle or universal adhesives perform as well as the two bottle or gold standards? And there's a couple different ways that you can look at this. I mean, we do a lot of laboratory testing in the research lab. We'll do shear bond or microtensile bond strength tests to compare the different adhesives, and it's really hard to differentiate. And sometimes it's just brand specific, depending on which adhesive will do better. The one bottle, sometimes one bottle adhesives can do very well and outperform two bottle systems in the lab. So I think the ultimate test usually will come down to clinical trials. With clinical trials, the big, when you compare adhesives, it's usually the non-carious cervical lesion or the class 5 type of clinical trials where you'll place, maybe two different restorations in a patient's mouth, one with one adhesive, one with the different, and you kind of follow them up. The minimum usually is studies will go maybe, an endpoint of 3 years. Sometimes you try to get out to 5 years. Really where the gold standard universal adhesives, a lot of people will talk about like Clearfill SE, which is a two bottle self-etch system, or Optibond FL, which is a two bottle etch and rinse system. So it's got phosphoric acid primer adhesive. They've got these super long-term, I believe they're 13 or 15-year clinical trials that showing it like almost 90% retention rates with class 5 lesions. And you don't see that long-term clinical trials with many other adhesives. And so that's kind of, I think, where they've gained the reputation for being the gold standard as far as adhesives. But so with universal adhesives, though, I think one of the longer term ones is one we've done at UAB is that we've got a 5-year clinical trial where we've got about a 96% retention rate with Scotch Bond Universal, using it in a total etch mode. So it's not, you can't compare that to something that's 13 or 15-year study, but you can kind of say, well, it looks like we're heading in the direction of having pretty good retention with this one bottle system. Theoretically, there's some disadvantages of one bottle systems, like you're mixing the hydrophobic and hydrophilic components of the adhesive into a single bottle, which is not ideal, because then you can, if you have a hydrophobic layer incorporated into your adhesive, you can have water from the hybrid layer or from the dental collagen kind of bubbling up through your adhesive, which isn't ideal. But practically, like I said, it may not. We're still kind of seeing, we're kind of median turn data where the one bottle systems are looking pretty good. So I don't know we can quite call them gold standard, but I don't know that we can quite say yet either that they're inferior to the 2-bottle systems.
Nice. That's always like from the clinician's point of view, as a consumer, we're just kind of going with sometimes what the rep tells us.
Yeah.
We hear from somebody who is an expert in the field and who can give us unbiased data to use and into clinical use, especially like evidence-based dentistry. That's where it comes from. So I appreciate you answering that question. Yeah. So in the next question being, what about self-adhesive cements?
Okay, so that's a great question, and it's funny. Like my my opinion on this has changed over time. And I was actually maybe about 3 years ago, I was going to write a paper about cements, and I was made the statement in there that self-adhesive resin cements were less retentive than resin cements that were used with a tooth primer. And anytime you write something in a paper, you got to back it up with some lit. So then I was like searching through PubMed, trying to find the lit to show what I thought to be true, that self-adhesive resin cements were less retentive. And I was looking through all these studies and I couldn't find it in there anywhere. And I had to change my sentence in my paper to basically say that there's not evidence that self-adhesive resin cements are less retentive than those used with a tooth primer. And then when we started doing it in our own lab, so we have the capability to do crown retention tests in our lab, and we were testing some of these new self-adhesive resin cements and found that they had comparable performance, particularly when we were talking about bonding to zirconia, as with ones used with the tooth primer. And so then I was like, well, I saw it. There's not really evidence in the lit that ones used with the tooth primer are better. In the lab, we're having comparable performance with self-adhesive and resin cements used with the tooth primer. So it kind of changed my worldview that, yeah, there are some, there's some brands that will do better than other brands as far as the self-adhesives, but you can have, and we've shown our lab and there's been other studies actually which have shown that too, which they've had self-adhesive resin cements perform equally well to those used with tooth primer.
Interesting. As an endodontist, in addition to that, like we come across a whole bunch of flack about as endodontists, everybody thinks or assumes that we are out to kill teeth. We do vital pulp therapy as well. And, and also we sometimes have to cement crowns back in place. So it's good to have this information and knowledge available out there. And you explaining the normal trend is to think one way, and whereas evidence suggests the other way, like you said, you had a self-revelation by the fact of exploring deeper into it. So yeah, that's neat. So the next question is, as an endodontist, we still do some composite restorations on immature permanent teeth, and of course in real-world restorative dentistry, there is a whole bunch of work which is done on cases where phosphoric acid is used to etch the dentin, and we want to question about is there a more post-op sensitivity when you're etching the dentin, or is that true or not?
So that's a great question, and this came up, and one of the reasons I wanted to discuss this is this came up in a discussion recently we had American Dental Association, something called American Dental Association Council of Scientific Affairs. We have this little group of scientists, and we were talking about this subject because we sent a survey out to a bunch of the members, and there was a lot of members that were nervous about etching dentin with phosphoric acid, and they listed the reason for being postoperative sensitivity. And I thought to myself, where is there evidence for this? And I happen to know, again, from writing a paper, that was my belief, was that if you put phosphoric acid on dentin, you'd get more post-op sensitivity. If you go through and you look at the clinical trials that have been done, similarly with class 5 lesions, where they've done some in a self-etch mode and some in an etch and rinse mode, they've seen no difference in postoperative sensitivity. Same thing, that's not just with some clinical trials. They've done systematic reviews and meta-analysis of many different clinical trials and came to that conclusion, was that they couldn't find a difference in postoperative sensitivity with systems used in a total etch and rinse mode. So that the only one place where and I did like this. There was, sometimes there's nuance in research, and one study did mention that in a practice-based research network. So that was where they were actually looking at uh, clinics, private practice clinics that were doing these restorations and reporting back to a center. They thought that they saw there that there was a slightly higher incidence of postoperative sensitivity when you used an etch and rinse. So like applying phosphoric acid on the dentin. And the reason they thought that maybe they didn't see it in academic clinical trials, but they would see it in private practice was maybe the type of restorations that were being done in private practice might have been a little bit deeper, because sometimes if you're doing a clinical trial, you're not going to do as big of a restoration or as deep of a restoration. So I mean, I guess that can be taken with a grain of salt, like the idea that there's no difference between the two. But I guess at least in moderate sized restorations, maybe then you wouldn't expect to see such a big difference. Maybe it would make a bigger difference if you're talking about deeper restorations where you've got, more open dentinal tubules that you could, if you etch them, maybe you'd see a little more post-op sensitivity. But for the general restoration, there shouldn't be a difference.
Yeah, and because I lecture as well, and we talk about how the dentin gets more porous as we go further towards the pulp versus the periphery. The tubules are wider in diameter as we go closer to the pulp. So of course, anything we do on the outside affects the inside. And I always think the teeth are like women; they don't forget anything. So it's cumulative damage. I call it as that.
Yeah.
So do you have any opinions on anything applied on the outside of the tooth? Like for example, chlorhexidine as a pre-rinse to reduce any microbial content on the surface of dentin. Have you had any? And of course, it has some research to support the fact that it can enhance the bone strength. Any ideas on that? Any opinions?
Yeah, no. So I mean, those the two things I always hear talked about and asked questions about is chlorhexidine and gluma. And I mean, you can think and initially when I started thinking about those two systems, you think about, I mean, one of their functions is to kill those matrix metalloproteinases, those enzymes that live on the dentinal collagen that get exposed when you apply phosphoric acid that can eat up demineralized collagen. So basically what it's doing is destroying our dentin bonds. And so chlorhexidine, 2% chlorhexidine, or gluma, which is a combination of glutaraldehyde and hema, can deactivate those enzymes for some reason. But yeah, like you said, additionally, I mean, they can be antibacterial. I didn't really realize that gluma was antibacterial. There's been some, I think TRAC, which is the Christensen's, they've got some data showing that gluma killing all these anaerobes, and they're big proponents of using gluma for its antimicrobial activity. I think chlorhexidine, that's what it's known for being, is an antimicrobial. So we definitely know that that's going to be antimicrobial. There's some other systems that can that will be incorporated in a bonding agent like MDPB, which is in Clearfill SC Protect. It's got a quaternary ammonia compound, which is has an electrostatic charge on it, which can kill bacteria, but it's in your bonding agent. So yeah, I think there's a lot of these things that you can apply to be antibacterial. A lot of, yeah, I don't know. I mean, one of the chlorhexidine is a very affordable one. I mean, it's a very, chlorhexidine isn't too expensive. So that's one that I think that I probably use more than anything else inside of cavity preparations. I would use them for MMP activity, but you could also use it for antimicrobial activity. And like I said, there's many different brands that make it, so you can get it pretty inexpensively. Are you a big chlorhexidine person, or?
I mean, we use it again for the same reason, for disinfection. And especially if I'm doing a pulp cap, I'll probably use chlorhexidine in an immature tooth before as a disinfecting agent. I mean, if sodium hypochlorite typically would be used when some of the pulp is exposed when you're doing a direct pulp cap. But if I'm doing an indirect pulp cap in an immature tooth, I'll do a chlorhexidine lavage before placing the direct pulp cap. Yeah, so same reason again. Yeah. And any ideas about, you mentioned NMDP with regards to how does that affect when a bond strength effectively deteriorates over say, let's 10 years? Is there anything out there which prevents that deterioration from happening? Because I know with flexion and the dynamic forces a tooth undergoes, is there any effect of any bonding agent which is more effective than the other?
Yeah, I mean, as far as like the MMP's degradation of bonds, I mean, I think that, yeah, that, I mean, the two strategies was with the chlorhexidine is, for, even though chlorhexidine is antimicrobial and MMPs are enzymes, for some reason, chlorhexidine seems to deactivate those enzymes. Gluma, I don't know if it's actually deactivating the enzymes, or Gluma is based on glutaraldehyde, so it's cross-linking the collagen. So it's like, you know, strengthening the collagen before you bond to it. So you're bonding to a stronger collagen with your hybrid layer. So I think those are two things that have been proposed for preserving the life of our dentin bonds. I mean, there's some of the evidence, one of the evidence that I think is a really neat study was they did these things that extract in third molars, where they would grind down third molars in kids that were going to have them extracted anyhow, and some of them they'd apply chlorhexidine, and some of them they wouldn't apply chlorhexidine. They'd leave them in there for a period of like 6 months to, I think, 6 to 9 months or something like that. Then they'd extract them and look at the bond. So they were actually in the patient's mouth getting potentially broken down by matrix metalloproteinases, and they found if you applied chlorhexidine that you would preserve the bond even in like a 6 to 9 months type time frame. So yeah, I think that there's some evidence that those things will preserve dentin bonds.
Cool. Well, Nate, this is pretty exciting and educational, and we're looking forward to more of these in the future. And any last words for our listeners? I know you have a dentinal tube page on in your Instagram, and also you have a very educational, resourceful website, natelawson.com. And I want to urge our listeners and viewers to look at those pages, because I really saw lots of good material on both those pages. So anything else you would like to add to that?
No, just thanks so much for having me. This was a fun discussion, and I like this. It's short and to the point. I like it.
Thank you. Thank you again, Nate, and we're looking forward to more from you.
All right. Thanks, Rajiv.